Good afternoon. This is Lacey Hong with the Alberta Medical Association, and I will be moderating the session this afternoon. Welcome to Clinical ARPs 101. Please note the information provided during this webinar is current as of May 29th, 2020, and may be subject to change. Next slide, please. Today we will hear from Dr. Rick Ward, family physician, Crawfoot Village Family Practice ARP, Dr. Richard Hanelt, family physician, Good Samaritan Seniors Clinic ARP, Dr. Ross, Pediatric Care Medicine, Calgary PICU ARP, Dr. Julia Carter, family physician, Sexual and Reproductive Health ARP. We extend our thanks to these individuals for their expertise and support today. This webinar has been approved for up to 1.5 Main Pro Plus credit. The evaluation link will be displayed in a web browser when you leave the Zoom meeting. Next slide, please. All participant microphones and video cameras have been disabled. Today, we will be using the question and answer feature in the Zoom control panel. The chat function has been disabled. You are able to ask a question at any time by clicking on the Q&A button from the webinar controls. If you're on a Windows device, this is located at the bottom of the screen. If you're connecting through an iPad, this button may be located at the top of your screen. You will be able to upvote your preferred questions by selecting the thumbs up icon. During the presentation, you should be able to see the presentation as well as the speaker. Clicking on the tiles may change your display. Next slide, please. Please note that the webinar you are participating in is being recorded. By participating, you understand and consent to the webinar being made publicly available via a link on the AMA website for an undetermined length of time. By participating in the question and answer, your name may be answered into the Zoom sign-in and may be visible to other participants during the webinar or during the recording. Next slide, please. We would like to recognize that we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 6, Treaty 7, and Treaty 8 territory, and is a traditional meeting ground and home for many Indigenous peoples. Next slide, please. This program has not received any financial or in-kind support. Next slide. The Planning Committee has contributed to the consideration of learning needs, the determination of learning objectives, the development of program content, and the choice of speakers or presenters. The Planning Committee has reviewed the content of the presentation and ensured that content presented is evidence-based and free of undue influence. As per CME requirements, all speakers and moderators have completed conflict of interest forms, and their disclosures are outlined on this slide. Next slide, please. At this time, I'd like to welcome Dr. Alison Clark, AMA past president, who will provide opening remarks on behalf of the board. Thank you, Dr. Clark.
Thank you. Good afternoon, everyone. On behalf of the AMA Board of Directors, I'd like to welcome you to the 9th webinar in our series, Maintaining and Optimizing Your Practice During Times of Rapid Change. The AMA remains committed to bringing you relevant and timely information during these uncertain and challenging times. Our webinars have been really well received, and we're still seeing a strong interest. We've had over 9,500 registrants to date, and we have another large group taking part today. Thank you for your feedback and suggestions for future topics. It really does help to shape the content we're delivering. During today's webinar, Clinical ARPs 101, you will have the opportunity to engage with peers, learn from them, and discuss the benefits and challenges of clinical alternative relationship plans. I was pleased to see the great turnout for today's session. Physician representation in ARPs is a critical issue we're facing as a profession. And as we all know, government is actively promoting clinical ARPs, and the AMA strongly supports clinical ARPs as a voluntary option for physicians as part of our physician compensation strategy. While there are many positive aspects to providing care through the clinical ARP payment model, no physician should be forced into making the move without all of the facts, careful consideration, and proper representation. This is particularly true in these uncertain times that we find ourselves in with respect to Bill 21 and COVID-19. As with previous sessions, today's webinar will showcase some of the great work being done by our members and will describe the key aspects that apply to all clinical ARPs, as well as the differences between clinical ARP models. Today's session is also about helping you to access AMA resources for further information and support. We hope that hearing the perspectives of experienced clinical ARP physicians will assist you in your own decision-making around payment models in your practice. And in my practice as well, I'm staying on for the duration of the webinar for me to learn as well. And with that, I'll turn you back over to our moderator to get us going. And thank you.
Thank you, Dr. Clark. Next slide, please. Our session overview for today includes key things you need to know about clinical ARPs, as well as perspectives from experienced clinical ARP physicians. This will be followed by a 30-minute question and answer session. Next slide, please. At the end of this session, participants will be able to describe key aspects that apply to all clinical ARPs, describe the differences between clinical ARP models, identify how to access AMA resources for further information and support, and utilize perspectives of experienced clinical physicians to assist in their own decision-making around preferred payment model. Next slide, please. At this time, I'd like to welcome our first speaker, Dr. Rick Ward.
Thanks very much, Lacey, and good afternoon, everyone. It's great to be spending some time talking about this important issue and giving my personal perspective on things. Next slide, please. I was sort of thinking about a line from Woody Allen where he mentioned that he'd taken a course on speed reading, and he further disclosed that after that he'd read War and Peace in one night. He said it's about Russia. So I guess my hope is that with all the potential information that you'll be getting in the next hour, that you'll think that this is more than just about Russia. Next slide. So to try and speed read it down, we have put together a top 10 list, and full disclosure, it says Rick's top 10 list, but actually the AMA sort of gave me a little help with this one. So next slide, please. So the top 10 things that I think are important to get across is number 1, or number 10 if you're going in reverse order, is that the government wants these. We've heard from the minister quite frequently in the discussions around COVID that the funding issues would not be a concern if people were on ARPs. We've heard from the McKinnon report before that Alberta lags behind the rest of the country in the number of clinical ARPs, and it was part of the UCP platform. The slide does demonstrate that there are relatively fewer ARPs in Alberta than there is in the rest of Canada. So this is coming, and it's just a question of whether this is for you. Next slide, please. So the segue of the next question is this for you? The AMA can help with this. I think the AMA can help in 2 ways. One is to help you to navigate the options in terms of ARP offerings. And secondly, to help model and understand whether an ARP makes sense in your clinical situation, and then moving on to assisting with an application process. What I would see as another key thing that the AMA can do is the whole area of change management, assistance in change management. Because one of the concepts that's going to come through today, I think, is that by making this leap to an ARP, it's more than just flicking a switch and practicing differently. There's a lot of change management that goes into that, which is actually a huge and cool opportunity. Next slide, please. So top 10, number 8 is that the funding is for clinical services only. So if I think about my experience at Crowfoot, we get paid a block amount of funding that's based on 80 common primary care fee codes. So that money all goes into a pot, but that money is a direct reflection of the services that we're providing as a primary care and the number of patients. So what an ARP doesn't do, on the next slide, is it doesn't specifically give money for vacation, for sick time, for administrative meetings, for research and teaching. Now, that said, the monies that you can take, that you receive in your clinical ARP can be divided out amongst those participating in a way that compensates for some of those things. So let me give you an example. When I was in the fee-for-service world about 25 years ago, the four of us who were practicing together at that time would get together for an hour a month for business meeting. After doing this for a few years, one of the partners says, wait a minute, you realize how much money that this costs by 4 doctors sitting together in a room and talking about the practice? This is way too expensive. We can't afford to meet. We just have to keep seeing patients. Contrast that with my world in an ARP. We spend lots of time looking at ways of delivering care, planning how we provide quality improvement and systems changes to be able to provide better care to patients. And as part of our ARP, we're compensated for that time. So actually being able to get off the racetrack, understand what's happening in our practice, how we can provide better patient care, how we can do it in a cost-effective manner. We can become compensated for that as part of how we have decided to use our clinical ARP payment. So it does provide that flexibility, but what it doesn't do is give you a big pension. So if you're holding out for that, probably this isn't your program. Next slide. So this, I think, is a really important slide that talks about what are some of the principles that should guide the development of an ARP. Sadly, some of these principles may have gotten forgotten or maybe de-emphasized over time, but I think it's a good place to start. And the best place to start is right at the top of this circle, which is voluntary participation. Shortly after we started at Crowfoot Village Family Practice, I thought to myself, you know what, if every primary care clinic in the province became a CVFP, we would have solved world peace, well, or at least healthcare issues. As I'm older, grayer, and less hair, I know that that's so not the case. An ARP will only work if you embrace those other principles and if you're going into it in a voluntary fashion. There are some practices where a Crowfoot Village Family Practice type ARP model would so not work. For example, my colleagues at the East Calgary Family Care Clinic, this Crowfoot type ARP would not work in that setting. So voluntary is at the top. Monitoring and evaluation, we'll talk about that a little bit later, the importance of accountability, support for infrastructure and tools. When we went to an ARP, we had to totally redesign how our office looked. Fair and equitable payment rates, that's something that you'll need to establish internally as well as part of the ministerial order. Best practice and highest standards of care. The ARPs, in my case, allowed us to do that. Very cool. Eligibility criteria we'll talk about a little bit later. I think the partnerships that the clinical ARPs have allowed us to form with AHS and particularly with our primary care network have really been part of the advantage. And I feel like I have more autonomy in my clinical ARP because I'm able to see patients and plan clinical service delivery in a way that makes sense for the patient, not that's being hamstrung by the rules of a fee-for-service world. Next slide. So The ARPs are governed by ministerial orders, and ministerial orders are an agreement between the group of physicians who are part of the ARP and health. It's not like a contract, it's more like a decree. And while you have input into that decree and there are responsibilities on both sides, it doesn't have the legal protection that a contract has, or at least used to have in the good old days. It requires a letter of participation from all those who are participating in the ARP model. There's an authorized representative or point person. Chris Bachmel is our authorized representative. And then if you are working in an AHS environment, there may be a services agreement with AHS. The ministerial order can be changed at any time by the minister with the caveats of notice, but it certainly does not give you the kind of peace of mind that a contract used to give us. And again, the caveat is based on the recent environment. Next slide, please. So I'm going to go through the highlights of this table. There's a lot of data in here, but I want you to just get a gestalt. So starting on the left side, the annualized and sessional payment models, which can be for family physicians or for other specialists, are based on either an hourly rate or a FTE rate for a year's worth of service. The sessional ARPs are really most suited for part-time participation for physicians who are working up to 16 hours per week. And there is the ability to bill fee-for-service for non-ARP activities outside. And there'll be, I think, an example of that that's discussed a little bit later. Annualized ARP is very similar, except it's based on an annual model. Now, you may look at those numbers and say, not bad, you know, $364K per year, I could live with that. 221 bucks an hour, I could live with that. Hold that thought, because that's not money that goes into your pocket. Let's go on the right-hand side. The capitation and blended capitation models are really primary care focused. I work in a capitation model, and again, what we get paid for that is on average $325 per patient per year. So that the advantage is we can look ahead and know what we are going to be budgeting for in terms of income for the next year. We then take that money and divvy it up, and I'll talk about that a little bit later. The difference between the capitation and the blended cap model, and the model in Sylvan Lake is the one that's a blended cap model, is that you're required about 15% of your income in the blended cap model comes from face-to-face delivery. So there's a requirement for more face-to-face care, whereas in the capitation model, we can provide care in whatever way makes sense for the patient. The other difference between the blended cap model and the capitation models is that the blended cap model is very complex in terms of how much is paid per person, because it's based on age and disease complexity, whereas in the capitation model, it's age and gender are the two. So that gives you an overview of the different kinds of models that are available right now. And again, we'll dive into those a little bit more through the rest of the webcast, and maybe opportunities for more diving at a later date. Next slide, please. So where's most of the money going now? Right now, the vast majority of ARP funding is going to these annualized FTE-based alternative payment models. Little less in sessional, and very little in capitation and blended cap models. Now, there's an invisible asterisk side currently not available to new applicants. We've gotten some pretty healthy signals from Alberta Health and from the ministry that a Crowfoot-like ARP will be available, but as of an hour ago, I can't give you a clear path to that. But I think if you look at the future and this slide, what we can anticipate is that the cap or blended cap models will see more interest and will be increased. That's certainly been the signals from the government. Next slide, please. Number 4, funding rate does not equal internal payment rate. Now, remember a couple of slides ago, I said, you know, $350K a year, that sounds pretty good. Well, the point is that payment forms the basis for the overall payment for your structure. So where that money goes depends on how your ARP is structured. So let me give you the Crowfoot example. So we have about 25,000 patients. We have an average funding of about $350 per patient per year. All that money goes into a big pool. What we do is we pay off our rent, we pay off our salary for our staff, we pay off all of our incidental expenses, we pay, and then with the monies that are left, we put that towards our physician payment model. So how physicians are paid within our ARP is something that we have control over. So the block funding that comes in to Crowfoot Village is then used to be able to run the business, to set our service delivery parameters, and also pay for our physician payment afterwards. What that gives us the flexibility to do is maximize our use of multidisciplinary team members who can work to full scope of practice and do things that make sense for the patient care and make sense for the business model. So for example, I'm not flushing out blocked ears, I'm not giving routine injections, I'm not changing dressings, unless I sort of want to, and some days I do. All that's delegated to our nursing staff. So it's a different way of looking at how to do business, and again, it allows you to become really patient-centric. Next slide. So there is accountability, and that accountability at present is in the forms of reports. I'll also highlight the very last bullet here, and in that last bullet is the whole concept of shadow billing. In our model, we bill every patient encounter that we see as a metric for demonstrating that we're actually doing things. So there still is an administrative burden for that billing piece, but it's part of what's required by Alberta Health, just to show that you're really doing something. Next slide, please. So number 2 on our list is really something that I've alluded to a little bit earlier, and that is that if you're going to go down the journey of developing an ARP, you need to spend time working together to be able to look at how you're going to deliver care to your patients and what the boundaries and the guardrails are. And just as important is then deciding on how to do the change management. I would say the secret sauce in this is leadership. And at Crowfoot, we were blessed to have Peggy Offrick, who was a visionary family physician, who came to the rest of us and said, guys, I cannot practice for the next 20 years by running on the hamster wheel of fee-for-service. Where I have to move patients through the office quickly in order to make a living. I want to be able to provide care in a way that makes sense to patients and that doesn't have those handcuffs of a fee-for-service world. So it was really her vision that has been able to move things forward and set the the tone and the alignment for us to develop Crowfoot over the next 2 decades. And we had a full year of change management as part of our initial transition from fee-for-service to a blended cap model. But I would say that the change management is a series of endless PDSA cycles. The downside of that is that you can really get change fatigue, and that you can feel that you're always walking into new territory. The great side of it is that you have the ability to dream the dream. You have the flexibility to be able to think about how you're going to deliver patient care and how you're going to do it in a way that's financially sustainable for you. So it really does bring together two important concepts, and we'll be alluding to that a little bit later on. But keep in mind, again, this is not flicking a switch to move forward. So my last slide, the number one is they are not perfect. The ministerial order is always a bit of a dance that we have with Alberta Health. There are some things that we think really should be changed, but Alberta Health says, not so much. It's not really a true negotiation. It's more a combination of horse trading and begging and working with the Alberta Health team with the assistance of the AMA to try to follow that North Star of good patient care in an affordable environment. You know, I think that the quadruple aim, efficiency of care, provider satisfaction, excellence in care, and access, if those are your North Stars in moving forward, then this will be a good journey for you. If you're going into this saying, I want to make more money, I think it's not the motivation to start with. Talked about the importance of multi-stakeholder governance and how that can be a challenge, especially if you're working with external organizations like Alberta Health Services. You know, those initial principles that I started with in my second slide really sometimes get a bit blurred in some of the negotiation process. The evergreening and updating of rates sometimes doesn't happen. And right now, as you'll hear from some of our speakers, the gestation between I want to do an ARP and getting on it is a little longer than one would hope or think. Next slide. So hopefully you'll come out of these 10 slides picking up on a few of these top 10 and not saying it's about Russia, but that it should serve as something to pick your interest and decide whether you want to continue the journey into ARPs. I'll have a little bit more to say about this in the later section, but I want to end just by reinforcing those key messages. And then going to the next slide, where I am going to introduce the second Richard of the afternoon, Richard Hanault, who is going to talk about his experience with an annualized FTE-based model at the Good Samaritan Senior Clinic, ARP. Richard, take it away.
Thank you, Dr. Ward. Next slide, please. Thank you all for coming to the webinar. I think this will be very helpful for people to hear our experiences. So I work as the authorized representative for the Good Samaritan Seniors Clinic model. I do also work in fee-for-service, so have a good perspective on different models out there. We started our clinic in 2004 and are a fairly unique clinic where we function as a medical home for complex seniors with the goal to keep them functioning as best as they can in their community and living at home and out of institutions. We do primary care as well as geriatric consults, and have another goal to help our PCN to provide care to seniors and improve their ability to provide care for seniors as well. We see patients in the home and in our clinic. We have a total of 4.8 FTEs, which is divided by throughout 9 physicians. And most of us work nearly full-time and some work part-time. Next slide. So in terms of the benefits, to keep this succinct, doing geriatrics in fee-for-service would not be viable. Our patients are highly complex, very time-intensive, heavy users of the healthcare system without programs like ours. We have significant on-call component and are available to our patients 24/7. Talking about the benefits, basically, this allows us to do geriatrics for our complex patients. Fee-for-service model is not feasible because of our small number of patients with a huge number of complexities and comorbidities. It allows us to work well with our team and do things that improve our satisfaction and patient satisfaction to function optimally to improve their health. Essentially, we could not do this work in fee-for-service. In terms of challenges, there's many challenges. Dr. Ward mentioned 5 things that we feel would be beneficial to work on in terms of opportunities for improvement. One huge challenge, I think, in the annualized model for family physicians is the definition of an FTE and what that rate is, and the fact that this is governed under ministerial order rather than a contract, and that physicians really have had minimal input into this definition. It's changed over the years since I've been working in 2004. This definition has been changed by Alberta Health. Initially, it was 208 days that we assumed were 8-hour days. Then it changed to 241 days with 1 billable event. And now Alberta Health is trying to change it to 241 8-hour days, which clearly there's a significant difference in those things. We are limited by our maximum FTE, so that can be a barrier for recruitment. If you've already maxed out your FTE and have a suitable candidate, you cannot hire them until you get an expansion. We've been working on an expansion for 6 years, and basically it's been turned down unless we're agreeable to change our FTE definition. There's a significant amount of reporting requirements in terms of shadow billing, reports in terms of patient numbers. A lot of the things that we're expected to report on are based on volume and don't necessarily fit with the objectives of quadruple aim. Next slide. Next, I want to introduce Dr. Catherine Ross from the Pediatric Critical Care Program in Calgary.
Hello, next slide, please. So I'm Dr. Kathy Ross. I'm the ARP representative for the PICU at the Alberta Children's Hospital. Our ARP was implemented in 2005. We actually had a letter of understanding from 2003. And our ARP developed because we had significant difficulty in the previous 7 years recruiting and retaining physicians. Our ICU is a 15-bed ICU with 5 flex beds, and we cover the ICU 24 hours a day, 365 days a year, regardless of how many physicians there are. And this is what brought about our recruitment and our development of the ARP, because we were unable to continually staff our ICU and provide safe coverage for patients with the fee-for-service model, because we couldn't attract recruits to come to work 1 in 2 or 1 in 3 as we had been. So our ARP allowed us to go from 2.5 FTE to 8 FTE, and that 8 FTE presently is made up of 13 participating physicians, 11 of whom are critical care specialists, and 2 are pediatricians, clinical assistants. Next slide, please. So our ARP development has been actually very successful for what we set out for, in that it has allowed us to have recruitment and retention, which then has ensured a critical mass of attendings. And this has had the benefit of preventing further burnout, and also to allow us time and energy to innovate and to develop further programs, which then contribute to improving the quality of care to our patient population. It has also allowed us an internal compensation framework that we developed so that we had the flexibility to be able to pay our physicians if someone went off on leave or was unwell. The coverage still has to happen. And this allowed us to be able to come up with a model that if you had to pick up work for someone else, you were paid for it, and you were paid for it immediately. So together with that, we also then were able to change our coverage models and develop quaternary level patient care programs, such as a rapid response program or STEP program, extracorporeal life support, pediatric transport, renal replacement therapy, and Code Blue, all of which we had been trying for the previous decade to develop, but because of difficulty with numbers, this was not something that we could add on top of our clinical load. So as a result, the ARP has enabled us to participate in indirect patient care activities and develop clinical practice guidelines, which have affected not only the ICU, but the Children's Hospital. We participate regularly in simulation team training and development of simulation programs. And this has definitely had an impact on patient safety and quality assurance. And then another spin-off of our ARP has been the ability to actually contribute and participate in research. The one thing that came out of this is that we have been able to participate in a North America-wide data system, which we're finally able to demonstrate our success in our ICU of providing high quality care. Next slide, please. So the benefits that we have definitely seen is a stable workforce of critical care physicians. We've been able to not only recruit, but retain specialist physicians, and thus distribute our workload and prevent physician burnout in a high acuity specialty, which is very well known in critical care. We've had stable funding, and we've had group control of funding, which is incredibly important in an area where you cannot just extend your wait list or your clinic time, that coverage has to be there. The ARP has allowed us flexibility for internally managing our funds and operations, and it has enhanced our multidisciplinary teamwork environment. All of this has contributed to patient safety and quality of care, and allowed innovation and program development, which again impacts career satisfaction and longevity of intensivist career time. The challenges, as has been stated by Richard, well, both Richards, is that there was a very lengthy application process. the expansion process that we underwent several years ago also took a large amount of time. The definition of a 1.0 FTE in hours of work, again, has been difficult to ascertain, and is something that we would like to continue to be able to work with Alberta Health and Alberta Health Services and the AMA. There is additional reporting. We shadow bill. We also report on our hours. And in some ways for an ICU, whether you have 1 sick patient or 15 sick patients, it's actually, you have to be there. And I'm not sure that the shadow billing or the hours emphasizes or the quality of care that is delivered and is not particularly a meaningful or measurable deliverable. We had a unilateral end to our contract and then a change to ministerial orders. And because of this, we have no legal recourse for dispute resolution or changes to services agreements with augmented services. It's challenging that there's a limited ability to negotiate new programs and responsibilities. And with this comes no ability to negotiate pay for these new programs. There's been challenge in terms of physician representation and input into the overall clinical ARP framework, and there's no built-in hours or compensation for overhead or administration of the ARP. Next slide, please. So I would like to introduce Dr. Julia Carter, who is a family physician with sexual and reproductive health and the ARP representative of this program.
Great, thank you very much. So yes, I'm a family physician also, and like Dr. Hanelt, and I also work in a fee-for-service clinic. So I spend about half my time in fee-for-service and the rest of my time working for a sessional ARP or in administration. So our sessional ARP was implemented in 2010, and a sessional ARP is paid at an hourly rate. So clinical time is funded at a rate of approximately $221 an hour. But that funding does have to include an overhead component, and it only funds clinical time. So our overhead component consists of some staff costs, some other administrative costs, as well as non-clinical physician time. Sessional ARPs are limited to 16 hours a week or less per physician. So most of our physicians work between 5 and 10 hours per week. And it's well suited for specialized programs. So most of the sessional ARPs in Alberta are for things like mental health, seniors care, addictions, dealing with vulnerable populations like refugees and so forth. And then there was a COVID ARP that was implemented quite rapidly to deal with some of the COVID work, both in PCN clinics and I believe in hospitals also. We are an AHS program, and so that's been quite helpful in many ways, because certainly we couldn't fund all of the overhead out of our $221 per week. We have large clinics with lots of staff. So our clinics tend to serve youth sort of age 13 to 29 primarily, as well as those with low income. We have a lot of complex people who've dealt with trauma, addictions, people who've been sexually assaulted. And most of our clinics have a 3-to-1 nurse to physician ratio. So we spend lots of time doing case consultations with our nurses. Our nurses do most of our lab follow-up, but they will do lots of consultation with us about patients that are not in clinic, and that would not be funded in fee-for-service, and then some complex case management as well. So we have 25 participating physicians, and I'm the authorized representative, and it's a mixture of physicians who have a regular shift as well as casual physicians. And we have a maximum number of program hours of 5,580, so we have to keep track on that and make sure that we don't go over, otherwise we don't get any additional funding. We've gone through 2 expansions, one when we added more, some IUD clinics because of IUD demand that we weren't able to meet, and the second when we implemented an HIV pre-exposure prophylaxis program. Next slide, please. So overall, our ARP has been a very positive experience for us. But there are some caveats, of course. We initially considered applying for an ARP partly because we were already funded at a sessional rate, but that sessional rate was paid by AHS out of pooled fee-for-service billings. And because some of our clinics, we would have very high volumes, and others they're primarily drop-ins. So, it's a beautiful sunny day and everyone's out on the patios, we might not see as many people. And so it made for big fluctuations in fee-for-service payments, and the funding was therefore quite unpredictable. So switching to a sessional ARP has given us predictable, stable funding, which has been very helpful. Also had a lot of troubles with recruitment and retention back when I first started as medical director, and it has certainly solved that problem. We have lots of people that quite want to work for us, and we have not had troubles retaining people. The AMA support has been huge. I can't say enough about the difference between when we first applied for ARP before the AMA physician support services were available. I just sort of describe that application as being like birthing an elephant. It took 18 months and was excruciatingly painful. But towards the end, the AMA physician support became available, and they helped us with our implementation. They've helped us with both expansions, and it's been a huge benefit. There are some additional reporting requirements, which I would put in the challenges category, although it hasn't been terribly onerous for us. We have to do 4 quarterly reports where we report on 7 different data items. So things like the number of IUD insertions, the number of STI tests, and so forth. And we were able to structure that because we're an AHS program so that we could use existing databases. So we're not having to collect the data ourselves. It would be a lot harder if it was a program that was not part of AHS and that did not have, we have one person whose part-time job it is to collect data and analyze data. So that's been super helpful. And annually, we report on about 20 different items, again, also chosen from our database. The one challenge we have had is with reconciling with our Alberta Health statements. So those of you in fee-for-service get the statements of assessment. We get similar documents, but it's for 25 physicians. The payments don't always match up to the days. And to try and reconcile it with the money that I'm getting in has been very, very challenging. So in order to figure out whether we actually are receiving all of the payments for the invoices that we've sent has been quite difficult. And at one point, the AMA was offering to provide us with some help with that. And they said, well, could you just fax us your statements of assessments? And I said, well, it's 1,000 pages. Do you really want all of that faxed to you? So, that's an ongoing issue, and we haven't had a good solution to that yet. And then the other challenge is time modifier tracking, and it's worth me spending just a minute explaining how that works. So a couple of years ago, in order to increase accountability, Alberta Health required that we switch to reporting our time using 5-minute increments. And it's not just a reporting measure, the funding is actually tied to those 5 minutes. So 1/12 of the $221 is tied to reporting one time modifier, or TM. So if you don't submit enough TMs, you don't get funded enough, but you still have to pay your physicians because they're still expecting that. So there was a lot of change management associated with implementing the time modifiers. And the reporting of time modifiers doesn't necessarily fit with typical workflow. We might be running a pregnancy test and doing some charting on one patient, checking labs on a bunch of patients, having a hallway consultation with a nurse, and then go back in to see that patient. And we've got to somehow track all of that time using 5-minute increments. So that's been a challenge. It hasn't been insurmountable, but it has required a lot of oversight and a lot of change management just to make sure that, we're recording all of our time so that we get funded for all of our time. I'd say the key success factors for our ARP has first of all been that we have an engaged physician group. They've been supportive of the change. They've done their best with reporting. We've had supportive management, because often there are different goals of the program versus what you need to support the sessional ARP model. And so I've been fortunate that we've worked with very supportive management. And then the AMA Physician Support Services has been tremendously helpful, because ARPs are quite complex and they have a lot of experience and can help sort of navigate our way through things. And I think that's all I have to say. So I would like to turn it back to Dr. Ward now to talk a little bit more about his CROFID experience. Thank you.
Thanks, Julia. We are, I guess, the old guys. So our capitation model started in 1999. So if I seem too Pollyanna about my ARP experience, it may be because I've just been drinking the Kool-Aid longer than most people. Crowfoot Village is a comprehensive primary care practice that we provide care to a defined group of about 24,000 patients, so it's a defined population. We have 16 physicians that manage those patients. None of us work more than 4 days a week. We have many of us work part-time. We've got a couple of docs who are practice sharing. We have a nurse practitioner who augments our team as well. It is a big organization. I think that when we have done our staff retreats and Christmas parties, I think that we've got like 60 people all together. So if you remember back in the old days when they talked about the optimal size of a medical home and talked about a 1-to-3 ratio for physicians to interdisciplinary team members, we're actually a little more than that. We've got a great relationship with our PCN, and that they really augment the team members that we pay for out of our ARP funding. The next slide really shows what we have felt quite proud about is that in fact those outcomes as a result of our practice change have really been demonstrated quite well in the Health Quality Council report. And I'll just pick up on a couple of the themes of questions that have come through. Well, how come there's only one Crowfoot? How come there's not a whole bunch? Part of the myth of Crowfoot Village Family Practice is, well, it's too expensive, and you're just seeing well patients, and it's a boutique practice. And the Health Quality Council report really hopefully put a nail in the head of those zombie concepts. That yes, upfront we are slightly more expensive, as is Tabor, the other capitation model. But if you look at downstream costs, we save the system lots of money. Most of that comes in terms of patients who present to ER with CTAS 4-5, or patients who need to be hospitalized. We have a lower hospitalization rate, and when our patients end up in hospital, their length of stay is shorter. So I think that the myth of Crowfoot is too expensive has hopefully been laid to rest, and the quadruple aim, which is cost savings, this is definitely for the system a cost-saving way of practicing primary care. Next slide. Benefits: comprehensive patient-centered care, improved access. We went through the AIM process. My patients used to say to me that getting in to see you, Rick, it was easier to get tickets to the Rolling Stones on Ticketmaster than it is to get in to see you. Now, my TNA time, third next available appointment, is anywhere from 1 to 3 days for a routine appointment. And our clinic TNA, so if you call and need to see somebody today, is 0 to 1 day. So we've really put an emphasis on access. We've got high quality care that's being delivered, and it's being done in a cost-effective manner. So the challenges is the lengthy change management process, and I'm so far away from it right now. I only have those positive memories. You know how when you go through a difficult time, sometimes you just remember the nice things. So I remember that as a time of being able to dream the dream, having the ability to be able to then deliver the nightmare. It's not really been a nightmare, but it's a good saying. And so that change management was a time investment, but it was also an opportunity to really create the kind of practice that we wanted to have. There really is, we have lots of administrative staff that support this. The benefit of that is the amount of paperwork that I as a physician do is thankfully very small. We actually have a dedicated staff who just do forms for us, so that they do our forms. We look at them, proofread them, sign them off. It's a wonderful thing. So for those of you who love paperwork, this might not be the way to go. The other challenge is negation. So what's a negation? So we get paid a set amount to look after a patient per year. And we get paid that whether we see them once a year or whether we see them 50 times a year. We get paid that much whether we deal with them over the phone, whether it's our nurse or the PCN pharmacist who's helping us provide care, or whether we see them in person. But if that patient goes outside of the clinic to be able to get their primary care somewhere else, then I have to pay for that bill. So every month we pay anywhere from, I'm not a detailed person, lots of money anyway in negations. Negations are about 7 to 8% of our total budget. And in some ways those negations can be very frustrating, but they also keep us honest. Let me give you an example. I wake up in the morning and my ear's plugged, and I'm put oil in it, and I'm shaking it, and I can't hear out of that ear, driving me crazy. I call up Dr. Rick and I say, oh, geez, you know, I'm pretty busy and I can't see you for a week or so. That plugged ear is not going to bother you. Patient says, well, it is bothering me, and I've got a walk-in clinic across the street, and I'm going to go over there and I'm going to get my ear flushed. I pay for that visit. So negation is in many ways a way of keeping us honest, because if I was to enroll a bazillion thousand patients and make lots of money in their rostering fees, but can't provide the service, they're going to go elsewhere and I have to pay for that. So negations are in theory, a way of keeping us honest. They're a way of ensuring that we're providing good care and we're providing good patient access, because if not, then we have to pay for those visits. The downside of negations is this. I recently took on a younger patient in his early 50s, male, with a metastatic cancer diagnosis. Now, remember, we get paid based on the average utilization for gender and age. So your best patient is your 95-year-old male or female who's totally healthy. Your worst patient, economically speaking, is your 25-year-old male with generalized anxiety disorder, because you get paid about $60 a year for the young male. You get paid about $400 a month, whatever, for your older patient. So this patient with the 50-year-old male metastatic cancer, we don't get paid a lot for that patient. So looking after his care, he's also getting care at the Tom Baker. Well, the person at the Tom Baker who was delivering his care was a GP extender. So within a month of taking that patient on, I had been negated for all of his care for a year, despite the fact that I was seeing him and his family quite a bit, discussing end-of-life issues and pain control. So negation is not perfect. In theory, it keeps us honest, but it has lots of downsides. Despite all of the challenges, I mean, I would not be practicing medicine if I was not able to practice in the ARP. It's energizing, it's fun, and for me, it's the right way to run the medical home for my patients. Next slide. So, taking my crowfoot hat on and putting my hat on as sort of directing this portion of the slideshow. So let's say that after attending this webinar, you say, I am ready to go. I think your first step would be contacting the AMA and helping them, having them help you navigate the application process. Alberta Health does have a direct number, but as a colleague, my suggestion to you is to work with the AMA, to work with Alberta Health to see about moving through the steps involved in an alternative payment model. We're ahead of time. We have lots of time for questions. I've seen that there's some great questions that are on the chat line. So maybe I will turn things now over to Lacey to help us work through those questions. Thanks very much.
Perfect. Thank you to all of our speakers. We'll now proceed with responding to your questions. Remember that you can continue to type your questions in at any time and upvote the queries you'd like to see addressed. Questions posed to our panelists may be summarized to address as many inquiries as possible. Given the volume of today's questions, we may not be able to get to all of them today. Questions not answered by our presenters will be addressed in an FAQ document posted to the website in the days following the webinar. Please note that some technical questions about clinical ARP rules and processes may be deferred to the post-webinar FAQ in order to engage the appropriate subject matter experts. At this time, I'd like to invite our speakers to turn on their video for today's question and answer period. Our first question today is for Dr. Ward. Dr. Ward, you mentioned that the Crowfoot model has demonstrated significant health system savings. What is your perspective on why Alberta Health has not made your model available to other applicants?
Yeah, thanks, Lacey. I'll give a softball answer to that. I think that there's lots of reasons. I think that there has been a myth for 20 years that the Crowfoot model was more expensive and that the system couldn't afford it. I think that the Health Quality Council report really helped to shed light on the fact that if you look at the system's cost, it really is cost savings. The analogy that Chris Bachmel uses is that if you go to the store and you're looking for milk and you buy a half a pint of milk, that's cheaper than if you buy the 3-gallon jug, 3-liter jug. But it doesn't really make sense. So I think for a long time people were focusing in on, but that half a pint of milk is a lot cheaper than the 3-liter jug. Then that really perpetuated the myth of Crowfoot being too expensive. I think we've got great data right now by an independent group that validates that that this model does work in this kind of population and for this kind of service delivery. And we've gotten some signals from Alberta Health and from the government that a Crowfoot model will be available for people who want to enjoy that kind of practice.
Thank you. Our next question is for Dr. Hinault. If your clinic was operating under a fee-for-service right now, and you were considering an ARP, what would be your biggest concerns?
Thank you, Lacey. I think that's a good question. A lot of the things we already discussed in the webinar, I think there's an important opportunity here to have some influence in improving ARPs. The AMA has created a working group to have a stronger representation for those physicians working in ARP and to give some guidance to Alberta Health for what things we think need to be improved on. I think one of those particularly is the ministerial order concept, that there really is a limited negotiation ability, that we've not had a very strong representation in terms of the issues, that this is not a contract. This is a ministerial order where the minister can make the decisions they choose to make. And even with physician input, it's often not done in partnership. Along those lines, I would think that the application and expansion process is
Alberta Medical Association,
very
Cal speaking.
complex. The application process is very complex, time consuming. It certainly would not be possible without the AMA and the ARP physician support services. As I mentioned before, I think the FTE definition has needed a proper review. This has been an issue for us for many years, and we're working towards that. And then I think it's important that this, be financially viable for a fee-for-service physician. And in my opinion, I think that the annualized model really is better for more unique populations and unique kind of practices. And honestly, our rate of pay is lower than we would make in fee-for-service for a regular family practice type setting. I think all those factors are really important ones to consider.
Thank you, Dr. Hinault. The next question is for Dr. Ross. The PICU is very tied into AHS operations. What is your perspective on physician autonomy in clinical ARPs? And has Alberta Health or AHS ever directed changes to your program practice or model of care against the wishes of physicians?
So I think, I think what is important to emphasize is that changes within a hospital system and Alberta Health Services have to be in conjunction with the people that deliver the services. And that has been our perspective, for the last 15 years, is that when programs need to be developed, or when we want to develop programs, it's a partnership with Alberta Health Services, and the negotiation with respect to taking on those services, we've been very fortunate to have the help of the AMA with respect to expansion to cover some of our programs. To say that have we been hindered? I would say we have not been hindered in developing programs, because for the most part, the programs we wanted to develop improve patient care. And so there is an appetite for that. Has there been remuneration or changes in terms of hourly expectation, both for the development of those programs as well as the administration and the actual participation in those programs? That has been challenging. So for instance, we started an extracorporeal life support system program, I want to say about 8 years ago, recognizing that there was a need for our patients to have that service, which was not available to us other than transferring very critically ill children to Edmonton for cannulation. And frequently the children could not tolerate the transport. So we were unable to provide that service. We have developed a service in conjunction with Edmonton where our surgeons cannulate and put patients on ECMO within the ICU with the intensivists, and an Edmonton team come and pick up those patients. You can imagine we don't have a lot of numbers, so we probably cannulate anywhere from 8 to 15 patients a year, which is not remunerable in terms of fee for service, nor is it something that in terms of hours we can justify. However, in order to provide that service to our patients, we have doubled our call schedule so that we always have a second intensivist available for an ECLS cannulation so that the primary intensivist can look after the other patients. There was no augmentation in our FTE or remuneration or hours for that service, but we felt it was very important for our patients and for the patients that we cover to provide. And so that service has occurred despite really no change in our FTE or so those are programs that is a negotiation, and I think that the fact that we have switched to a ministerial order from what used to be a trilaterally agreed contract, we have lost the ability for programs and program development because of that, and that's something that I think the AMA will be a huge player at representing the physicians and hopefully improving patient programs and care and quality going forward.
Thank you, Dr. Ross. Dr. Carter, the next question is for you. You mentioned that you work in your program under a sessional ARP and in a primary care clinic under fee-for-service. From your perspective, which payment model do you prefer?
I mean, I think there's no question that I prefer working under an ARP. It's just much more stable funding, and I can really focus on what the patient needs and what our team needs. But there's an important caveat to that, which is that our program is an AHS program. So the lease and salary obligations are with AHS. And we pay a portion of staffing, but we don't have the obligations there. Whereas in my fee-for-service clinic, I have the lease and salary obligations. And, I don't think under a ministerial order I would feel comfortable expanding those obligations. As well, the hourly remuneration, I don't think would fund a program that's outside of AHS or something that's got some other source of funding. So definitely when I'm in clinic, working in a sessional ARP is great. I really enjoy the work. I really enjoy the team, and I really enjoy that I can focus on what the patients and team needs, but there are some important caveats there.
Thank you. The next question is for all of our panelists today. What is your perspective on physician flexibility in a clinical ARP with regard to working hours and vacation time off?
I'll take a first stab at that, Lacey. In our clinical ARP, we've got huge flexibility. Again, the North Star is meeting patient needs. And if you're meeting patient needs, if that's your guiding principle, then how you do that and the flexibility that you use is secondary. So I would say that it gives us lots of freedom.
Thanks. Any other perspectives on that question?
I would speak, our model is such that we set our schedule. Obviously the ICU has to be covered 365 days a year, 24 hours a day. And so our group works amongst ourselves to set the schedule according to FTE, and we actually allocate according to work units. And we decide what those work units are and what is remunerated for what time, as well as vacation time, which is set by the group. And the reason for some of that is that we need the flexibility. If I'm hit by a bus tomorrow and I'm supposed to be working for the next 10 days, different kinds of shifts, somebody has to pick it up regardless. And so the ability of us to, within our own group, make those changes and make those decisions has been huge.
I'll speak too. In our model, we have some flexibility in terms of this question. However, we're bound to our FTEs. So if we work over our allotted FTE, we get no extra funds. And if we work under our allotted FTE, we return money back to Alberta Health. And eventually that doesn't look so good on the program, and they may cut your FTE ultimately if you're consistently working under your allotted amount. So as an authorized rep, it is quite challenging. Every year I ensure all of the physicians in our group are working what they've committed to work, and it's somewhat difficult to keep it very close to what you're allotted.
And ours is very straightforward because we're a straight hourly rate. So if you work, you get paid for the hours that you're working. If you give up a shift for whatever reason, someone else covers it and they get paid instead. So it's pretty straightforward.
Thank you. The next question is directed to all panelists as well. From your perspective, what sort of characteristics would make a practice more suitable to exploring a clinical ARP? Maybe Dr. Ward, if you want to start us off.
Yeah, sorry, just having trouble with the mute button. So I think, so what are I think the prerequisites would be, number one, physician alignment. Physicians have to agree on practicing a different way. And there's certain principles that make a capitated model work. I think that that you have to have a patient population that recognizes the importance of continuity of care, and that will accept that their medical home is the place where is the center for getting their primary care. So for patients that don't put a premium on the medical home concept, do not embrace or are not able to access care from your clinic or choose not to, those conditions would not work well. So I use East Calgary Family Care Clinic, where they have high needs populations that often have social challenges, social determinant challenges, and have barriers to accessing care in the usual way. It's a very difficult, that would be a group that would not lend itself to this kind of an ARP, the blended CAP ARP. It would lend itself very well to another kind of ARP, but not a capitated or blended CAP model.
Perfect, thank you. Next question to any of the panelists. What is the flexibility in the design of an ARP? Can some services be included and other excluded? Or how many physicians need to participate, and what kind of specialties can be included?
I mean, I can speak a little bit to the flexibility in terms of when you write the application. It's sort of like writing a master's thesis. It's, I can't remember how long ours was, 20 or 30 pages with quite a lot of detail about who does what different professionals in the clinic. And so you can design the program. There are questions that will come back from Alberta Health, and so not everything can get be successfully implemented, but certainly for the sessional ARP there was a fair bit of flexibility. I'm not entirely sure about whether it can be a combination of primary care and specialty care, but maybe someone else could answer that. And I'll let others speak to what the flexibility is of other models.
I can comment on that for the annualized model. In terms of, I agree with everything Dr. Julia Carter mentioned. The application's lengthy, you have to define what you do, and it gets reviewed by Alberta Health. There is opportunity to have different specialties. For our program, we're all family physicians with interest in geriatrics, so we are based on the family physician rate. If we wanted to add, say, a psychiatrist or a internal medicine trained geriatric physician, their rate and FTE rate is different, so that has to be in the application.
And I would echo that. For our program, we actually have 11 critical care specialists, and we have 2 pediatricians who work as clinical assistants within the ICU. And that was part of our expansion process, where we have a blended model of nurse practitioners and CAs to extend coverage, particularly nights and weekends, and a different coverage in the daytime.
Thank you. Dr. Ward, can you comment on continuity? How challenging was it to achieve continuity for your practice, and how did you help patients understand the importance? What impact did it have on your work hours, et cetera, in order to maintain that excellence for continuity?
Yeah, great question, Lacey. I think that most of our patients crave that continuity, and in the primary care world, we know that continuity, relationship continuity, and continuity of care is associated with all those positive metrics and outcomes. So part of our change management strategy was essentially educating our patients that we want to be your first stop for primary care. So we created the mantra, call us first. And we gave little badges and phone magnets so that we created that culture of saying, call us first. For the patients that would come to us and would say, well, you know, I don't really want to call you. I've got to walk in next door. I want to see you once a year for my annual physical, but I can't guarantee that I'm going to call you when I have a problem. We would say, well, you know, here's why we think relationship continuity is important, and this is the philosophy of me as a practitioner in this practice. If that doesn't work for you, maybe we're not the best medical home suited for you. So there was that strong piece when we were transitioning of educating our practice. The other part of that was saying, you know, you may not need to see me for everything. So if you call in the morning and say, OMG, I just woke up with a runny nose and a sore throat, and I think I need to come in and see it before this gets really bad, what will happen is you will likely get our nurse who will say, well, do you have this? Do you have that? Do you have this? Well, you know, here's what you should do. We think this sounds like a virus. It's going around. Here's your self-care measures. Call us if this happens. If you're really concerned, let me call you in a couple of days to make sure that it's getting better. If as a patient you say, no, I want to see the doctor when I'm feeling that way, we would say, you know what, maybe this isn't the kind of practice for you. The last piece is that when patients join our practice, we spend about 20 minutes talking to them about the philosophy of Crowfoot, talking about how we have team-based care, and how important that continuity piece is, and the consequences us as a business if you negate us, and that patients will sign a contract with us. An enrollment form really specifies that. So we try to be really clear up front about mutual expectations, and it doesn't work for some patients. So those patients will select out, and the patients that are remaining will be more philosophically aligned to your style of practice.
Thank you. Is there a minimum amount of time that an ARP physician must work? And this is directed to anybody who chooses to answer.
I can
I
comment.
think, sorry.
I was going to
Okay.
certainly not in a sessional ARP. We have some doctors that just work a few hours a year. That creates issues with keeping up their skills, but from an ARP perspective, there's no.
I would say from a specialist model, what we determined within our group, which was our group determining a minimum FTE of 0.5, was in order for all of us to feel that the skill set that they were required to have could be maintained. So we have no one that is less than a 0.5.
I can comment as well. In regards to the application process, I believe there's a critical mass required for Alberta Health to accept this. Perhaps somebody from AMA could comment on that. And I agree with Dr. Ross. In our group, in order to maintain continuity in medical home practice with continuity with our patients, we've requested a minimum of 0.4 FTE from our physicians.
Thank you. We have about 5 minutes more remaining. So as a reminder, unanswered questions will be responded to in the post-webinar FAQ. Please note that given today's popularity of the ARP webinar, we will be looking into potentially delivering a series of ARP-focused webinars in the near future. So I think we have time for 1 or 2 more questions here. Dr. Ward, do you think the average family doc makes more money with an ARP or fee-for-service?
Yeah, so let me answer it this way. How do you make the most amount of money in fee-for-service? You do quick patient touches. You get people in and out of the office as quickly as possible. You bring people in for quick recall visits. You refer out anything that's complex, and that you probably write more prescriptions, because it's a lot easier to do that than explain why you don't need a prescription. Like I said, I've been drinking the Kool-Aid. So how do you make lots of money in a capitated system? You work with your team and ensure that the right patient is seeing the right provider at the right time. That allows you to maximize your panel size. You emphasize to patients self-care, so chronic disease self-management and prevention, because those healthy, self-managing 90-year-olds, they're gold. So you want to empower your patients. So it depends what kind of doc you are. If you like those quick episodic touches, bang them through, you know what, a capitated model probably isn't for you. If you like the concept of working within a team, of sort of looking at your panel and looking at providing care in a different way, and maximizing your ability to have a big panel by utilizing an interdisciplinary team, then you're going to do better in that model. So it's a bit of a politician answer, but you can do really well in both systems. I think you have to start by saying, how do I see myself wanting to provide patient care? Again, Peggy Offrick's words were, I want to get off that treadmill. I want to get off that hamster wheel of having to see 30, 40 patients a day in order to pay for my overhead and staff. And that was really the genesis of Crowfoot, is I can provide quality care in a different way and still have financial security.
Thank you so much for your response. So that's our final question for this afternoon's webinar. In closing, I'd really like to extend our thanks to our physician members for participating in this webinar, the AMA board for their support, and of course our presenters, Dr. Ward, Dr. Hanelt, Dr. Ross, and Dr. Carter. If we could move to the next slide, thank you. Evaluation is an important part of our CME accreditation process. If you have time, please feel free to use the evaluation link provided following this slide. we can move to the next slide. Thank you. All right. So the webinar has now come to a conclusion. Stay safe and healthy, everyone. Goodbye.
Thank you.
Thanks, everyone.